Okay, let's dive right into this. Welcome to this explainer, where we're going to tackle something that I know keeps, well, a whole lot of nursing students up at night. We are decoding next generation NCLEX or NGN case studies. Have you ever wondered why some people can just breeze through these incredibly complex scenarios while others get completely lost in all the noise? Well, I'm here to tell you, it's not just about having a smarter brain or, getting lucky. It's about a very specific skill. It's a way of filtering clinical data to find those subtle red flags buried deep in the charts. So today, we are going to investigate exactly how to ignore the distractions and pinpoint the patterns that actually matter, using a really powerful overarching framework called the Rule of Three. First things first, let's validate what you're probably feeling right now. When you open up that electronic health record in a case study, you are immediately hit with just a wall of information. Multiple tabs, lab values, vital signs, nursing notes from 3 different shifts, med lists, imaging results. It is completely overwhelming. And as this quote perfectly captures, your brain is drowning in data. But here's the secret. That is completely intentional. Actually, scratch that. It's more than intentional. The test makers are basically clinical evil geniuses. They design these modern NGN case studies specifically to distract you. They know that under pressure, most students are going to just grab the very first abnormal finding they see and run with it. So how do we stop falling for that trap? Well, we have to learn the difference between high-yield data and filler information. It's kind of like panning for gold. High-yield data, that's the gold you're digging for. It's the recent vital sign changes, new lab trends, current assessment findings, acute changes from the patient's baseline. But to find it, you have to wash away the filler. And that filler is just surface-level distraction designed to trap passive readers. We're talking allergy histories from 5 years ago, yesterday's discharge planning notes, or stable chronic conditions that literally haven't changed a bit. They're just there to take up space and drain your cognitive energy. Washing away all that filler requires a massive shift in your mindset. You've got to stop passively reading the case study like you're just casually scanning a chart. Instead, you need to start actively hunting for the actual problem. Every single time you open a new tab, you should be asking yourself, okay, what changed today? What is new? What is trending? By asking those questions, you immediately stop drowning in the noise and you start zeroing in on the meaningful data. And honestly, this is more important now than ever because the exam has fundamentally changed. The 2026 NCLEX updates shifted something absolutely critical. In the old NCLEX, things were pretty obvious, right? A patient has chest pain and shortness of breath, boom, obvious myocardial infarction. But the new NCLEX is a totally different beast. Now, a patient might have completely stable vitals and a normal chest x-ray, but wait, their troponin was 0.04 yesterday, and now it's 0.08. Their heart rate just crept up from 68 to 78. They're slightly restless but denying any pain. You see, the obvious symptoms are gone. You literally have to act like a clinical detective hunting for those really subtle trends. To catch those subtle trends, we use what's called the cluster method, and this is a foundational skill for the Rule of Three that we'll be mastering shortly. The cluster method is where we look for 3 minor, sometimes even normal findings that when put together signal an impending crisis. Let's walk through patient A's case to see how this works. Step 1, their temp is 98.8. Technically normal, right? But step 2 tells us their usual temp is 98.2. Plus, step 3, their white blood cell count was trending up yesterday. Any one of these findings on their own, you'd probably ignore it. But clustered together, these 3 subtle clues form a narrative thread, signaling that an early infection is brewing. It's the story the data tells across multiple tabs that separates the safe nurses from the misdiagnoses. Okay, let's test your instincts with a psychological trap that gets almost everyone. Imagine you've got a diabetic patient who is actively showing symptoms of low blood sugar. They're sweaty, they're shaky, maybe a little confused. The obvious knee-jerk clinical instinct is flashing red in your brain right now. Do you give them dextrose now? Now, what's really interesting about this is the distractor reality. Let's look at the full clinical picture. Do they have a recent insulin injection? Yes. Do they have symptoms of hypoglycemia? Yes. But look at their blood glucose level. It's 95. That is completely normal. If you fell for the trap and chose to give dextrose, you'd be treating a symptom that isn't actually there. You see, test makers prey on your instinct to quickly treat what looks familiar. And that brings us to the test maker's absolute favorite psychological trap, the red herring. A red herring is a clinical finding that looks really critical on the surface, but is actually a completely expected finding for that specific patient's condition. It's the ultimate gotcha moment. It's designed to make you panic and select the wrong priority. Let's look at a classic example of this. Say you have a patient with severe kidney disease. You see a creatinine level of 8.5. Your brain screams, "Whoa, that looks terrible." But wait, for a patient with established severe kidney disease, that's actually an expected red herring. It's logically consistent with their baseline. The actual emergency, it's that same patient with a potassium level at 6.8. That is the acute, life-threatening issue. Your job isn't always to find the right answer immediately. Honestly, a lot of times, your job is simply to eliminate the logically inconsistent patterns so the real emergency has absolutely nowhere to hide. To do that, we use the elimination protocol. It's incredibly straightforward. When you stare at a list of findings, interrogate them. Is it expected for this disease process? Toss it out. Is the patient completely stable on that front? Ignore it. Does this finding have nothing to do with what actually changed today? Cross it off. Whatever survives this really aggressive filtering, that's going to be your correct answer. But how do you apply this when the data is scattered everywhere? Because NGN case studies are multi-directional. You've got notes from day one, meds from yesterday, vitals from an hour ago. It's a lot. The technique here is multi-tab synthesis. You need to create a mental timeline. Start with day one. What was the oldest data? That's your baseline. Move to day two. Okay, what changed yesterday? Finally, land on day three. What is changing right now, today? By forcing all that scattered data into a chronological timeline, you reveal the patient's true trajectory. And when you build that timeline, you're looking for one specific game changer, the silent change. Silent changes don't scream, "Emergency," with flashing red lights. No, they're the lab values that are technically still acceptable, but are undeniably worsening compared to yesterday. They're the vital signs that are in the normal range, but are slowly trending in one single direction. It's a patient who is quote-unquote stable, but becoming increasingly restless. These silent changes are exactly where the crisis is starting, right under the surface. All right, let's talk about the moment of maximum cognitive pressure, the number 6. This represents the dreaded 6-item matrix question. You're staring at 6 different interventions, multiple checkboxes, and your brain is threatening to just completely short circuit. I mean, it is the peak of exam anxiety. So how do you maintain your pattern recognition clarity when you're faced with this? You counter it with the number 3. This is the ultimate tool for avoiding panic selection and maintaining absolute clarity. It's the overarching framework we've been building towards this entire time. We call this the rule of 3 validation. Before you check a single box, you run your hypothesis through this mini validation checklist. Number 1 asks the big question. Does this intervention actually match the primary patient problem I identified? Number 2 demands evidence. Does it align with the specific clinical cluster we just talked about? And finally, number 3 forces prioritization. Is it the highest priority, most urgent action to take right now, or are there safer actions that need to happen first? So the crucial point is, if all 3 of these align, you have confidently found your answer. You can lock it in. But, and this is a strict rule, if any of those 3 do not align, you must question your choice immediately. Do not just guess. Do not just go with your gut if the evidence doesn't support it. This framework forces you to stop, step back, and evaluate your logic before you make a potentially fatal flaw in your case study. And this brilliantly illustrates the whole point of mastering this strategy. When you learn to filter high-yield data, build timelines, and apply the rule of 3, a magical shift happens. You stop seeing scattered facts and you start seeing a patient trajectory. You transform from a confused, overwhelmed test taker into a strategic, highly capable clinical investigator who can connect the dots across time. And let's be totally clear here. This isn't just about passing an exam. This is real-world clinical judgment. When you're on the unit and your patient technically looks stable, but something just feels off, you're gonna trust that feeling because you've trained your brain to spot those silent changes. You're using these exact same skills to catch early sepsis before the patient crashes. You're recognizing the cluster to prevent a fall. You are advocating for your patient when the data just doesn't add up. This is exactly the kind of safe-thinking nurse the NCLEX is designed to create. So I want to leave you with this final thought. Will you be the nurse who catches the silent change before the crisis hits? By mastering pattern recognition, the noise fades away, and these complex case studies become honestly entirely predictable. Now, if you want to dive deeper into these prioritization frameworks and see some full, real-world case study walkthroughs, I highly recommend checking out Pathways NCLEX Review. Your breakthrough is literally just one pattern away. Thank you so much for joining me on this explainer, and hey, keep hunting for those patterns.